Hello, my name is Dr. Ahmed Abdelal, and today we're going to speak about motor speech disorders. And this is an introductory level intended for students of communication disorders who are studying intro to speech, human communication disorders. So we are going to speak about exactly how we produce speech, because in order to understand abnormal speech, you have to know how normal speech is produced. The textbook Gillam does not address that. They should. And then we're going to speak about the two major kinds of disorders that are motor disorders that have a heavy impact on speech, and especially we're speaking about speech apraxia and about dysarthria of speech. Within dysarthria of speech, we speak about cerebral palsy because it is a major cause of dysarthria. So in terms of normal speech production, we need more than 93 muscles to work together, to coordinate together, to produce a single word. And that means that you need air to inhale, and then the air that is exhaled. As you are exhaling, you need to use your organs of speech. Organs of speech are either muscles like the tongue, or they are like organs like, say, cartilage or bone, like, say, the jaw is bone. But what moves the jaw are the muscles. What moves the muscles are the nerves. So the nerves get the signal from the cortex of the brain, and these signals come down through the nerves and then activate the muscles, and the muscles make your organs of speech move. So you need to coordinate the breathing, especially like the breathing muscles and movements and so on, with the phonation. This phonatory system, the larynx, gives you a buzz. Just that. It makes a buzz. Ah, and then that buzz, it exits through the articulatory system, which is your vocal tract and your nasal, your vocal tract includes the oral cavity and the nasal cavity. So as the sound exits through the oral cavity, at different locations, different organs of speech interrupt and constrict the passage of the air. And as you can call it, kind of chopping that air stream or the buzz from the vocal folds, chopping it into individual sounds and words and phrases and so on. So this is the integration kind of, on the level of the musculature working together. And all of this coordination is done in the brain. So there are systems in the brain, especially the brain stem, for example, that regulate breathing cycles, inhalation, exhalation. There are centers in the cerebral cortex that control planning of the movement. Before you move, your brain is going to make a script. It is going to it has maps of the muscles. Where is this muscle located? Exactly what areas does it have so that it can perform the movement? How much energy it has? A lot of calculations are there, and maps about the space and about the muscles and so on. So there's a lot of motor planning that occurs at before you do any movement. But this motor planning has to be integrated within the linguistic and the cognitive scripts that you make. Like you want to say, I'm going to call and place an order for a pizza. So before you call, you need to know what you're going to say. So that is the linguistic script. and also linguistic cognitive kind of, because you know what a pizza is, you know its name, you know when you see it you recognize it, but what exactly is the concept of a pizza? What is, you know, it's as an object and it has certain features and so on. That is part of your cognition. So before you speak, your brain has to establish a linguistic cognitive script of the meaning of what you want to say, and generating the words and the ideas that you want to give to someone else. And then on the other side, your nervous system also has to generate a script of the movement, the dimensions of the movement. Go up, you know, twice, go down twice, go forward, go back, and all these muscles and the movements that they make, these are mapped, and the planning, motor planning areas make plans for every sequence of movement that you are gonna make. So these cognitive linguistic scripts are overlaid onto the articulation scripts, onto the motor planning scripts together, and they are then fed into the motor activation centers that will send the signal to your nerves, and the signal brings the signal then through the nerves goes to your muscles, and these muscles are connected to the organs of speech, or like I said, they could be the muscles themselves could be by, like your lips and your tongue, for example, could be the performers of the movement. So let's look here and explain a bit. I'm gonna go here first. So this is a map here of your the area here is a map of your movement. Voluntary control is here. You can imagine this area to basically have like little like engines, one engine to move your lips, one engine to move your jaw, and like little areas here, that are connected to each organ. Every part of your body that has voluntary movement is controlled by this little strip here. And you can see if that strip, if you want to map it exactly, the area that is, this goes in between the two sides of the brain. So we are speaking about here, this is inside the two hemispheres. And imagine like if this little person is called the homunculus. So that is speaking about the motor homunculus, the motor map of the body. So here, this area inside and between the two hemispheres controls your toes, and then as you go up, this area controls your ankle. You go up, controlling your knee, and you go and here your torso, and every part is mapped onto this little strip that is called the motor strip or the primary motor cortex. So then the lower 1/3 of that cortex, which is here, lower 1/3, is dedicated to the control of speech musculature, face, neck, and shoulders. I'm sorry, not shoulders. The face and the neck, like including inside and outside, basically speech production and swallowing and feeding. Neck in front of that motor cortex, there's a little area here that is for planning, called the premotor cortex. And as you go lower in front of the foot of that premotor cortex, these two little gyri, this area here that has the word speech, that is called Broca's area. And Broca's area is responsible for motor planning, and for grammatical processing, and for having the lexicon, the vocabulary. And it works with many, like 11 major pathways that connect it with other areas here in the frontal lobe and the sensory areas here. In the back here and behind, by the way, All of this blue area is the frontal lobe. So the major, speech planning and speech production involves heavily involves the motor cortex. However, there are pathways in the sensory motor cortex and the parietal cortex here. There are pathways that connect with the planning areas. So just to make it simple for you, I'll say what I said, but just looking at the map. First, the story of how you make speech. You want to say, place an order, using a phone, you're going to place an order. First, your frontal cortex, the prefrontal cortex, the very end, the farthest area in the front, generates your plan and your intention to make a particular, movement, to do something. Say, I'm going to make a call. So then it's going to immediately, as you have the intention, let me get the catalog of the movements. Let me get the catalog that has the scripts for, I'd like to assemble a script for speech to say what I want to say, and then how I am going to say it. So this area works with Broca's area, with the pre-motor area here, which plans for motor behavior, and they work with the sensory areas. The sensory areas here give you feedback about how your muscles are actually performing in the real world, and they also give you the maps about the orientation of the muscle, the limit of the movement, the strength, and how it feels when you stretch that muscle, when you contract that muscle, for example, how does it feel, and so on. So all the sensory information in the parietal lobe is integrated with the information, the motor maps in the prefrontal cortex, or the premotor area here, that generates the motor plan. So then they work with Broca's area, and they also work with an area here in this temporal lobe called the Wernicke's area. These three together, through major pathways, they give you the motor script, and they give you the linguistic script, and they integrate everything. You are ready, but now you need to give the command to make the movement, actual movement. So finally, the actual movement is finalized by the prefrontal cortex, sent to the speech area, Broca's area, and after this, now the plan by this time is rehearsed many times, and it is edited and refined, and everything is ready. So then it is sent to the motor cortex here in the area, to the areas that you want to activate. Like here, for example, you want to activate your tongue, your lips, your jaw, and your vocal folds. So all of these are going to be receiving the signals now so that they can be activated. So the signal goes down through a special pathway that connects the cerebral cortex with the brain stem, with the roots of the cranial nerves that move your facial musculature, your neck musculature, your laryngeal musculature, and so on. So that pathway that connects the cerebral cortex with the roots of the nerves, that is called the pyramidal pathway. Pyramidal pathway. With it also travels the extrapyramidal pathway. One of them gives you motor activation, and within both of them, they give you sensory feedback as well. So you have from fibers coming from the motor areas, from the planning areas, and from the sensory areas. All of these make up the pyramidal pathway, or the pyramidal tract. I'd like you to know that the pyramidal tract connects, or both the pyramidal and extra, but the pyramidal tract connects the cerebral cortex with the roots of the muscles. With the roots of the nerves that connect with your muscles. And the muscles we are speaking about are the muscles that are connected with the organs of speech or are part of the organs of speech. So when that signal comes down, it will travel through the pyramidal tract down to the brainstem, and then the brainstem, you have all these cranial nerves, 12 of them on each side. They receive the signal, and the signal goes, for example, to activate, let's say, to activate your tongue, for example, to activate your the muscles, for example, of your face, and so on. So that is how it works. And the muscles, the only thing a muscle can do is to contract, to shrink, to kind of contract. When it contracts, it pulls the organs or structure that it is connected with. So that is the story of speech and how you generate it. Now, all these areas I mentioned, the premotor area, the motor cortex, the frontal association areas, Broca's, Wernicke's, and so on, all of these have a system of pathways that connects them. So you have centers that have particular functions, and then you have pathways to make circuits that enable the integration and the performance of the movement. So then we have two very important pathways now that connect the areas I just spoke about. And these are, they are called the language streams or the language processing streams. This pathway in the temporal cortex, it is called the ventral, the purple one here. They both originate out of an area next to the auditory cortex that gets your sounds in from your ears. So this area that is next to the auditory cortex, this area here is called Wernicke's area. And out of Wernicke's area, there is a pathway that goes on down underneath the belly of this this area from below, and it goes out forward, and finally it connects with the Broca's area here. So that's called the ventral pathway, ventral language stream or ventral pathway. In short, it is dedicated to the processing of to the comprehension of language. It allows you, it enables you to assemble sounds together and to construct the word, but that word only has an auditory structure now, and you do not know what it means. Like if you say cat, okay, a cat, what does that mean? Then that system here works with other systems to allow you to assemble the meaning of that word cat. So it's an animal that has this and this and this and that. So that maps auditory structure of the word with the linguistic meaning of the concept itself. So now you can comprehend what you are hearing. So that is the ventral stream. Now the upper stream, that is split into two pathways, simply is called the dorsal, because that's on the back of, it comes out of on the back of Wernicke's area and the primary auditory cortex. It just goes out and it connects with the planning areas for speech. So the planning are Broca's area that has muscular, it has the motor plans, and the linguistic or syntactic plans, and the lexicon. So this area here is working on the scripts, and the premotor cortex also has a pathway, and that is also part of the planning. So this system, the dorsal system, in short, is responsible for overlaying the kind of the motor script with the linguistic script together to give you a speech motor script, and to rehearse that script and make sure it is refined and it is free of errors, and it is the best and most economic in terms of energy, and it has the shortcuts that are necessary to make speech in the best and most efficient way. Efficient here means two things. Means done within a short period of time, within a good time limit, and done accurately. That is what efficiency is speed and accuracy. So now, the dorsal stream is responsible for overlaying the auditory word form onto the motor plan, and also for integrating the motor plan with the speech script plan. And then finally, now with that is going to get the everything ready, and the script then will be sent back to Broca's area, and from there it will go to the motor cortex, and the motor cortex is going to send it down through the pyramidal tract or pathway. It's going to go down through that pyramidal tract, and from there to the roots of the cranial nerves that control your speech musculature. That is the story of speech. So now, we will be able to understand better when we speak about speech disorders. Apraxia is a disorder of speech, like involving the production of speech. And you have a video here that shows you, it's an excellent video from the Mayo Clinic that explains it, and it also shows you many cases of children speaking. So apraxia can be congenital, that the child is born with it, or acquired. Some brain damage happens after birth, anytime, and then if it affects the same structures, the person will have apraxia. Like certain people have strokes, and certain strokes are result in apraxia as one of these. Then we have dysarthria. That also can be congenital or acquired, and the acquired kind includes about 6 different types. So for childhood apraxia of speech, we call it childhood apraxia of speech because there's like I mentioned, it can happen in adults, but when it happens in adults or older people who are, after birth, that is the acquired kind. So we are speaking about the developmental kind. Apraxia. Praxis means movement coordination. Apraxia means lack of, like typical, atypical. It is a system, a problem of brain networks. Now you have muscles. The person has muscles that are intact. All like the oral structures, or all the organs of speech, all the muscles are strong and intact. That is, they can do everything like feeding and do totally. When you look, the person is fine. However, when they speak, their speech is not fine. When you look at the centers of their brain, the particular areas, like, how they do their work, you will find that they have the vocabulary, they have all that they need. However, it is the pathways that are not efficiently performing their role. And as a result, sometimes they call this disorder an ideational problem. It is it's a cognitive. It's about the ideas that you have and how these ideas are generated and how they are transmitted to the motor system that actually moves the muscles. So the person who has apraxia has intact muscles and intact muscular strength. However, when they speak, or you ask them to say something, the speech just comes out totally, it comes out different. They don't have full control over their speech mechanism. And again, watch this video. It is extremely enlightening. Children also who have apraxia, they have speech developmental problems. They have speech sound difficulties as well. And but the motor development is totally fine. So then we have acquired apraxia of speech that can be caused by damage directly to Broca's area. Remember, Broca's area has planning for motor planning, and it also it passes the command to the motor centers. Acquired apraxia can cause slow speech and disfluent speech, like interjections, and as we discussed in stuttering. Flat, monotonous intonation. It's like a machine, speaking. The person can't raise their voice, lower it, or raise their pitch and bring it down to make your speech dynamic. It's a skill that all of us know how to do spontaneously, but people who have apraxia have difficulty, and they tend to have a flat tone that is characterized as a monotone. Like one monotone means the same loudness level, the same pitch level. That's what a monotone is. That is what you get when you listen to a recorded machine or synthesized computerized speech, the old systems, I mean. In terms of how common it is, 1 to 2 children per 1,000. That's worldwide. The causes have not been yet identified, and there's a little bit of disagreement in terms about the etiology, the cause. The characteristics or the diagnostic features in terms of speech apraxia, the words are mostly simple. The person would just stick to monosyllabic words, and they stick to early developing sounds, but sounds that require a lot of pressure, like ch, j, and zh, particular kind of pressure. They have difficulty with these. They are more complex. They have many vowel errors. Their speech production is inconsistent in the sense that they do not make the same mistakes. So, but someone who has a speech sound disorder, like articulation problems, they make the same mistake. Every time the child doesn't say the L, say in any word, they will, every time they say a word that has the L, they don't say the word or replace it with something else. That is consistent. But in childhood, an apraxia of speech, the errors are not consistent. In other words, they don't make mistakes on the same words always. And the intonation is different, and the stress in the words is different. Just to give you an idea, in language, there are words that are stressed. All words that have one single syllable carry a primary stress. If the word has more than one syllable, one part of it will be stressed. But in the result of when we speak, we have to mix stressed syllables with unstressed syllables in a system that makes music. For example, the song "Row, row, row your boat gently down the stream." You can feel it in this "Life is but a dream." So stress, unstress, stress, unstress. So this is how it goes. And singing and all depends on how you coordinate the stresses with the unstressed, the stressed with unstressed syllables in songs, so that you can produce a particular effect, whether that is sadness or animation and liveliness and so on. So that person, in other words, will have difficulty conveying emotions and conveying particular effects through the tone of their voice. In terms of acquired apraxia, of speech, because we say of speech because there is apraxia of limbs called limb apraxia. Like say, touch your nose, you go like touch everything else but your nose, not your nose. You make a lot of movements before you perform the desired movement. So it is involves that acquired kind the same. It involves the planning and programming system of speech, and especially in the left hemisphere, and especially in the frontal lobe of the left hemisphere. That is because language fundamentals like words, sounds, sentence structures are all in the left hemisphere. The left hemisphere is dominant for these. And then in most cases, again, some patients who have strokes, who have Broca's aphasia, where Broca is damaged, Broca area is damaged, they also might present with apraxia of speech as well. They tend to have also speech sound errors, and some of the sounds will be imprecise, like the S is not as clear and crispy. The sounds like P or the sounds that require a lot of pressure are just loose and lack that pressure. They substitute simple sounds, like they replace complex sounds with simple sounds. And the prosody, again, prosody and intonation are basically the same. That modulating your pitch and your loudness levels, that is prosody or intonation. So that is characterized by a slow rate of speech. The person is speaking slowly, and the consonants are extended, making longer consonants and vowels, and they make a lot of pauses between words. And then even stress on syllables means they make a monotone, monotonous speech. Hello, my name is Dr. Abdelal, and I am the professor who's teaching you this intro to communication disorders. And if you do not understand anything, you really have to go and stand. Sorry. So that is monotone. So now we move on to, before we move on to dysarthria and CP, again, remember, dysarthria, apraxia, it means it means that the person has intact musculature and everything is okay, but the pathways are not communicating well to produce the intended speech plan. So in terms of dysarthria, it involves different parts of the central nervous system and or the peripheral nervous system, and also the pathways. So that makes it a muscular problem. In dysarthria, the muscles are impaired, weak, paralyzed, the different levels like hemiparesis. So weakness and sluggishness and some cases paralysis. So the planning areas do their work. Everything is okay there. However, the muscle itself is it is not moving. And of course, that is a result of how the signal is sent and, from the brain. So it's a muscular problem. So as a group, for example, these systems, the neuromuscular pathways, peripheral and central, all of them, they tend to be impaired. So if someone has dysarthria, in addition to having hand in the hand is almost paralyzed, then they have weakness in the muscles also at the same time of the chest and the back. Muscles of the neck are decreased. All muscles in the body are affected by this. And then the velum is sluggish and not active. The lips, all your vocal folds. So that affects respiration, phonation, resonance, and articulation. Resonance is the using, for example, especially using the velopharyngeal port, closing and opening the velopharyngeal port that we spoke about before, the lifting up the velum and down when it is appropriate, and also the way that the sound is transmitted into the oral cavity and nasal cavity. So there are, based on etiology, based on the cause, dysarthria is classified into congenital, means the person is born with it, and especially as a result of cerebral palsy, and acquired, and that is most of it is acquired, and that is when the person is, or had damage due to stroke or due to brain injury of some sort. So based on the physiology, like the symptoms, what the organs of speech are doing and so on, dysarthria is classified into, what the muscles generally do, because we said it involves all muscles in the body, basically. So dysarthria is classified into 6 major types. We have the flaccid kind, the spastic kind, ataxic kind, hypokinetic, hyperkinetic, and the mixed. So it's an easy list. First 3, flaccid and spastic, are opposites. And then ataxic is a mild kind of form. And then hypokinetic and hyperkinetic are opposites. And then you have a mixed that can have either can have a combination of these. So let's touch upon CP. It's a syndrome of deficits that result from injury to the nervous system at or shortly after birth. That is prenatally, before birth. At birth or after birth. So it can also be caused by prenatal problems. So the muscles are weak. They could be paralyzed and or uncoordinated. So the dysarthria is one of the major, or the kind of developmental dysarthria is primarily attributed to cerebral palsy. So let's talk a little bit about CP. It can be caused by prenatal issues like anoxia, oxygen deprivation before birth, due to the wrapping, say, of the cord, or maybe to any other kind of problem, and disease. For example, disease during pregnancy, metabolic problems that are caused by abnormality in the placenta or abnormality in the cord itself. Perinatally, after birth or during birth even, there's the risk for anoxia, like oxygen deprivation because of the cord still wrapping around the neck, and also premature separation of the placenta, and brain trauma. So in terms of postnatal, like after, later, brain trauma can cause CP. It comes in different levels of severity and different kind of many different forms. One form could be very, very mild that you could barely notice. But generally, if it involves one limb, we call it monoplegia. If it involves both, you say means paraplegia, means both legs. If it is 3 limbs, you say triaplegia, and quadriplegia for 4 limbs, all like legs and arms. So there is spastic CP, and there's athetoid. So the spastic kind, spasticity means rigidity and stiffness of muscles. It is caused by damage to the pyramidal and extrapyramidal tracts. The spasticity is obvious. So this tract here that connects the motor system with the cranial nerves. The spasticity basically is abnormal resistance to the muscle lengthening, which means stiffness and rigidity. There is hypertonicity, so an abnormally high muscle tone. Arms and legs are arms are bent forward like this, legs are positioned like crossing each other, and there's muscular atrophy. Atrophy means shrinkage of the muscles. Muscle atrophy, because the movement, most of these people are bound to, chair bound, wheelchair bound. The athetoid kind, the primary damage is to the basal ganglia, inside of the basal ganglia. This is a system that's in the core of the brain that coordinates movements and also communicates with the prefrontal cortex and the planning areas, motor cortex and the planning areas, and it also controls the force of the movement. So that, for example, someone wants to do something, they can just jerk very quickly, or you say make a circle. If you make a perfect circle, you have good muscle tone. But your muscles kind of keep jerking, and they are not able to make a smooth kind of movement. So that is the basal ganglia. These systems are responsible for a refinement of the movement, for coordination, and for controlling the strength and the force of the movement. The child, again, is constantly kind of moving and making like different movements, twisting, writhing constantly. Ataxic CP is caused by damage to the cerebellum. The cerebellum here, the main function, one of the primary functions of the cerebellum is to receive the motor plan, script of the motor script. This is the plan. I want to say these words. I want to say them this way. I want to say them using these structures, these organs. So it receives that from the prefrontal cortex. Then it also receives from below, it receives feedback from the muscles that are performing the movement. And then the cerebellum compares what is intended, compares the speech motor plan with the actual movements, and it identifies the errors and sends them up to the prefrontal cortex that had planned the movement, to the pre-motor areas that prepared the scripts, and to the motor cortex itself. So that cerebellum enables the person to correct the movement as the movement is ongoing. So again, it edits motor commands by comparing the intended motion or movement with what is with the actual movement. So the person with ataxic CP, you could see with this little explanation, this will make sense, that will have a problem with motor coordination that particularly involves errors in speed and direction and accuracy of the movement, because the cerebellum is responsible for identifying errors and feeding the feedback into the planning areas and the motor execution areas. The person will have difficulty with tasks, for example, difficulty in motor tasks involving a target, like, point to your nose, point to your forehead, touch this, touch that. They will have difficulty reaching that target directly. Difficulty in motor tasks involving precision and rhythm. So, for example, playing drums, or that will be a difficult task. In terms of the severity, we go the same. Any kind of disorder, we just have this system, 3 major categories: mild, moderate, severe. And then we have the combination, because things are not always clear-cut like that, say mild to moderate or moderate to severe. And You can just read this. I do not want to consume the time of the video telling you things you already can read. And so these are the characteristics of each kind of CP, mild, moderate, and severe. In terms of speech and language development, respiration, we discuss phonation and resonance, because all of these are impacted by CP. So the person will have a reduced vital capacity, means the amount of air they can have in their lungs is limited because the muscles are impaired, and the person usually is kind of bending like that, which restricts the amount of space that is available for breathing and available for speech. So in effect, they have, because of the vocal folds being weak, the person cannot make adduct them strongly to increase the pressure beneath them. They cannot put enough pressure into their speech, into generating sound using the vocal folds. So as a result, also they have in this area here, they have in the velopharynx, this area here between the velum and the pharynx is the velum is sluggish. It is not very active, and the person will have hypernasality, as you could see here in terms of resonance. When we say resonance disorder, can be either hypernasality, hyponasality, or something called cul-de-sac, where there's a obstruction up here and obstruction in the oral cavity. Usually when someone has like very large tonsils and very large adenoids, they would have cul-de-sac resonance. So these are the three things I just wanted to explain. In terms of phonation, the person again can, the voice may be breathy or can be strangled and harsh. Also, just because if there's the rigidity in certain parts of the body, that can kind of overflow to the vocal folds, and that can make them kind of, their speech can be jerky. And I worked with a lot of these children, by the way. So these are the characteristics of speech produced by children who have CP. In terms of articulation, the mouth is more opened than it usual, which is called hyperextension of the jaw. Difficulty rounding or protruding the lips, abnormal tongue positioning, and so basically all of these kind of make it hard for the person to shape the sounds, and especially along the vocal tract, and articulate the sounds normally. In terms of prosody, because of the poor, there's a limited amount of air in the lungs. They don't have enough to generate like great pressure. The loudness will be decreased. They would have difficulty changing their pitch. They would in effect have a flat tone and poor laryngeal control, and they cannot again manipulate pitch. So they will have difficulty expressing their intentions, like, are you asking me a question or making a statement? Do you mean, are you excited when you are saying this, or are you disappointed? It's hard to know. All of these are conveyed in the prosody, in the tone of your voice. Dysarthria of speech, again, it's a muscular problem. The muscles are weak, just sluggish or paralyzed, and they just cannot give the speech, even though everything up there is fine. There's a video here that shows you a very interesting case, a young man with dysarthria, and you can see his speech. Listen to his nasality, listen to how slow he is, how he speaks like this, slow, and every word he will take a breath, simply because there is not enough air in the lungs. The muscles of the chest are weak, the muscles of the back, the muscles of respiration and phonation, everything just weak, and he has to stop and stop and stop to take a breath and continue talking. This is why. So there is flaccid dysarthria, it's like kind of hypo and kind of sluggish muscles. Here's again a patient with flaccid dysarthria. The damage is caused by the motor unit that is in there are two kinds of units. One is called the upper motor neurons and the lower motor neurons. But the upper motor neurons tend to be affected heavily in that, in terms of speech. There's muscle weakness and atrophy, shrinkage, because the muscle that's weak, it's not used enough, and then it's not used enough, it is shrinking. Rapid fatigue with prolonged use, and hypernasality. That's because the velum is just sluggish, it can't go up, and you listen to it when you see the patient who has dysarthria, the first one. So as a result, the velum is like hanging down, and air is escaping while the person is when it is not supposed to escape. The also nasal emission, like sniffing as you speak, that the air just comes out and you can hear it. Breathiness, and then when the person is rested, simply because that's a muscular problem, when the muscle is rested, it can perform again, it can improve functioning. So there's increased difficulty also over time. As the person continues to speak, they will tend to have more difficulty. The spastic kind, again, remember spasticity involves rigidity and involves stiffness. So this kind of dysarthria is characterized by bilateral damage to the pyramidal tract and to the extrapyramidal tract. These two, the right side has its own system, the left side has its own system. So when we say bilateral, it means both systems. That's heavily, both of them are impacted. And there's hypertonicity, means rigidity of muscles, muscle rigidity. The muscles fight against stretching. If you try to stretch, like the person's like this, you try to stretch, they're just resisting you. They have difficulty with articulating sounds precisely. The speech rate is slow, and the person speaks in very short phrases because of the difficulty with coordinating breathing. The voice is harsh, and the person again has reduced loudness, and the pitch sometimes it goes up and kind of and it goes down uncontrollably, because that spasticity it gives you that rigidity. Ataxic dysarthria, also it's called Friedreich's ataxia. There are two cases here. You will find this one very interesting. Well, about the patient. He's a young man, and it is heartbreaking, but it's a fact of life that you need to understand this. It's a mild case, but unfortunately it's progressive. And this one is an informative video that explains to you what ataxic dysarthria is. So basically, it results from damage to the cerebellum, and remember the functions of the cerebellum. So that speech is characterized, the movements of the muscles are inaccurate and dysrhythmic. They are not just flowing in a natural, like breathing, for example, has rhythm. You take in air, and every time you inhale, if you are resting normally, every time you inhale, 40% of the time is taken inhaling there, and then 60% or so is or maybe 55% even involves the air, the exhalation of the air. Every time you breathe, if you are sitting and just naturally not doing significant activity, every time 45%, maybe 55% out, just like that. That is rhythm. But that is not the case with people who have ataxic dysarthria. You could imagine now speech is monotonous. The reflexes are abnormal. Like if you get a spoon or say an object and stroke the size of the mouth, the person just goes around trying to grab this with his mouth or her mouth. That's a baby reflex, but they just, because of that damage, that has to do with the motor unit damage that is causing these reflexes. If you put, say, something in their mouth, like say, open your mouth, I'm gonna put this on your tongue, the tongue depressor, they're gonna bite on it. That's called the biting reflex. So things that at 6 months or 7 months should disappear in terms of life, like 6 months old or 7 months old, they just can be caused by this kind of dysarthria. The weakness, as you could see from the video, the person is walking, and if you look at him, when I looked at him initially, I thought he was an actor. I mean, he's very handsome. You couldn't tell, but when he started speaking, you could listen to the little differences in his speech. So that's there's minimal weakness, and speech intelligibility is mildly affected. It's just a mild form of dysarthria. Hypokinetic and hyperkinetic, they are opposites. The hypokinetic kind is, kinesis, by the way, means movement. Hypo means slow. So the hypokinetic dysarthria, it often occurs with Parkinson's disease, and that involves damage to the dopamine cells in the basal ganglia that I showed you earlier. The person has hypertoned and rigid muscles. Muscles are stiff. Resting tremor, like if they are sitting doing nothing, they just, their hands shake and their maybe head, or so. Even the vocal fold is gonna have a tremor. Accelerated movements and short rushes of speech, because you want to do something, all of a sudden it releases, and then you just kind of have difficulty controlling it after it gets released. They have a mono pitch and mono loudness. So that means flat tone. The first patient I worked with as a speech pathologist was someone who has hypokinetic dysarthria. It was just an amazing experience. So here's a patient you need to watch and see the characteristics. And then hyperkinetic, it involves damage to the basal ganglia of the that involves the extrapyramidal tract kind of connection with the basal ganglia. There's involuntary movements that may be fast or slow. The movements may occur in one side, one limb, or the whole body. And of course, for speech, prosody is flat, intonation is, the tone of voice is flat. They make articulation problems, errors, and the rate of speech is slow. Again, here's a patient that has Huntington disease and who presents with hyperkinetic dysarthria. The mixed kind, again, is a mix of different characteristics, and that occurs in multiple sclerosis, ALS, and progressive neurological diseases. And the effect on speech depends on the kind of impact that the nature of the disease itself that is causing the dysarthria. So here's a summary of all this that we've discussed. And in terms of assessment of dysarthria, we focus on speech production. We look at the oral facial symmetry and oral facial musculature, and inside and outside, rate and range of movement. You could see in the British video that is there with the patient, the clinician made a line here that is basically to enable you to see that the face is not symmetrical. It allows you to identify facial asymmetry, especially when she talks and the face is tilted to one side. So we do this oral peripheral mechanism exam, looking at the structures, how intact they are, and examining their different movements in the, like say, lift up your tongue, touch here, push, and put this tongue depressor in front, extend your tongue from here to touch that, and here, and here, and there, and ask them to do a lot of activities to measure, to assess how they move their muscles of speech. And there's also a test that is particularly for a test battery for people with dysarthria and kinds of movements. And also the speech exam, kind of in terms of speech examination, there's a speech intelligibility test for dysarthria. In terms of intervention, sometimes some patients might need to be kind of positioned in a certain way. For example, if they're like this or hunched like that, simply by having them sit up, you're going to allow more air inside of the lungs, and they can breathe in a better way so that they can project their voice and they can build up more pressure. They also, some of them would benefit from a reduced rate if the rate of speech is slow. Is fast. You are going to improve the precision of the movements and the accuracy of the articulation, and also enabling them to monitor themselves in terms of vocal intensity, how loud their voice can be. And like I said, this can be different from patient to patient, from type to type as well. Sometimes, especially when the velum is inactive, it's sluggish, they use a palatal lift that is similar to the one that is used with people who have a cleft palate, and that cleft palate is intact, like it is long enough and everything, but it is not able to lift up to do its job. So the purpose of this is to stop the hypernasality. The purpose of the palatal lift is to prevent or to stop the hypernasality of the voice. They also could do this with a pharyngeal flap as well. So the vocal folds sometimes are paralyzed, and in that case, they could do injection with Teflon, or for example, to puff up that vocal fold that is inactive, so that the other one can reach it. Or if that vocal fold is adducted, is like the person has the problem and this is stopped when the vocal fold is far away, they can reposition it and bring it to the midline like that. So that brings us to the conclusion of this lecture. And again, I hope that you find it helpful and that you have watched the videos that I put there. I didn't want to make this video longer by showing this, but you need to view them yourself. Thank you, and we stop here.